Okay, so we're going to continue with our discussion on the etiology and in particular etiological search. Um, we can do this with biomechanical dysfunctions. What we can't really do too well is the etiological search for medical dysfunctions, medical diagnoses. But both start off the same way. You make a diagnosis. Now in medicine, looking for the etiology often requires um, lab tests, imaging, and so on. We've got access to none of that. So our role in this is not to look for etiology. It's barely there to make a diagnosis, and any diagnosis we do make is provisional on the objective studies backing us up. However, biomechanical dysfunction has no backup. There are no lab tests that can be done. There are no imaging studies that can be done. So the diagnosis is ours. We're right or we're wrong. Now, in both cases, though, the etiology search cannot begin until you have a diagnosis. I mean, if you do blood tests on every patient who walks in, a gamut of blood tests, some of these are going to be positive and some are going to be negative. The positive ones may actually be false positives in as much that they're not part of the patient's complaint, and the positive ones may be false positives for the same reason. They may be, all of this may be irrelevant. So if you go in with a diagnosis, you have an idea of what's relevant and what's not relevant. You can still get false positives, false negatives, but without that context behind the test, things just go from bad to worse. And it's got to the point where the American Medical Association have stated that there are way too many imaging studies and lab studies being done before a diagnosis has been made. So they're using these studies to make the diagnosis. It's the wrong way round. The imaging studies are there to confirm the diagnosis or look for etiology. With us, we have the biomechanical statement. This is an extension subluxation in this such and such joint. We know the direction of the subluxation. So if we go ahead and look for stuff, this is hidden in etiology now. Patient's making a complaint, say the knee, that's where their pain is, and you're looking for causes of that pain. And most usually the causes of that pain, a biomechanical problem, are going to be quiet. That is, they're not getting symptoms from the etiologies. You just don't go in and look at everything, take everything on board and say, okay, we're going to treat everything we find. There's a good chance you're going to find the thing you want, that you need, but you're going to treat a whole lot of bunch of stuff that shouldn't be treated because it's not part of their problem. So you have to go in knowing what you're looking for. This is no different from saying, okay, I've got a diagnosis of cancer here. We're going to do some imaging. I know exactly what I'm looking for. I'm going to ignore the stuff that doesn't match this diagnosis and I'm concentrating on the stuff that does. This is really no different. You look for the stuff that is likely to cause the patient's complaints. That is what's causing this diagnosis. And it's as simple as that. So you've got to stay in context, and your findings have to be relevant to the patient's complaints. If you do that, you won't go too far wrong. Etiology searches are interesting, and often they yield results. And if the thing is, though, if you've got a hypomobility causing a symptomatic problem, and you treat the symptomatic problem, say with manipulation, and then you rehab it, but you don't get rid of the hypomobility that's causing it, you'll rehab basically the patient's musculature couldn't control this when it was healthy. Now it's dysfunctional muscle, and you're trying to rehab a muscle that's already failed once and it's probably going to fail again. So you have to take the stress off of that joint and not just treat the joint itself. Okay, so when we're searching for etiology, it's probably the best way of thinking about this is to categorize our effects and influences by where they are. So we're looking at intra-unit influences. When I say influences, I mean etiologies, contributors, compensators, all within a functional unit. And then we have effects that span the functional unit. So effects that run the entire quadrant. Things like long leg and short leg appear in this as well, as does segmental facilitation and axoplasmic flow issues. When we're looking at more global problems, these are actually quite rare in our everyday lives. They're often neurological, and they're not a big influence on most of our patients, but they're worth considering, but not in this program. We'll grab that in a more advanced course. So looking at the intra-unit, or the functional units in the lower quadrant, we have the foot unit, which consists of the foot and ankle, which breaks down to the forefoot, midfoot, hind foot, and then the inferior and superior tibiofibular joints. And if you're wondering, the superior tibiofibular joint is functionally part of the foot for our purposes. Anatomically, it may be part of the knee, although it's often not in the same capsule, but functionally we're going to consider it as part of the foot. Then we have the lumbar pelvic unit, which is the lumbar spine, the SI joint, and the hip. And in the middle of these two massive bullies is the knee, and this is what tends to get beaten up by the foot and the lumbar pelvic unit. And here we have the tibiofemoral and the patellofemoral joints. So we'll be coming back to the knee often during this whole approach to etiologies in the lower quadrant, because this is where a lot of these problems occur. And this just gets beaten up by it. Let's have a look at the forces and effects within each unit. Mechanical, as I say, this is the largest, most dominant influence. In the lower quadrant, because you've got gravity pushing body weight down into the ground, ground reaction forces pushing up, and so these things are going to be dominated by mechanical forces, mechanical influences. In the upper quadrant, though, gravity really doesn't play a role, not a compressive role anyway, and there certainly isn't any ground reaction force unless you're an acrobat. So here, the dominant theme is neurophysiological. So back to the lower quadrant, mechanical, hugely influential. First principle is the more massive bone will move the lesser massive bone much more often than the less massive bone can move the more massive bone. It's as simple as that. So if you're trying to figure out what came first, whether or what caused what, the lesser massive bone is unlikely to be the cause of a more massive bone breaking down. It's going to be the other way around, almost always. The mechanical effects can be aseminal, descending. They can be caused by forces coming up as ground reaction forces, or forces going down as gravitational forces, and more likely it's a combination of both. So the leg gets squeezed between these forces, essentially. Compensation is normal, and the best example I can give of this is leg length inequality. Now, we all have this, but your body compensates for it. So if your right leg is long and your left leg is short relative to each other, then the right leg will try to shorten and the left leg will try to lengthen, and it does it very well. And you can go through life, as we all do, with one leg a bit longer than the other. Nothing breaks down, everybody's happy, and off you go. Overcompensation, though, is where this breaks down. So if I've basically got a long leg, and the long leg is trying to shorten, and there's one or more joints in there that's not mobile and not allowing that shortening to occur, the other joints taking part in this shortening will start to break down, becoming hypermobilized and then destabilized. So what you'll often see with a long leg that can't be compensated for properly is that the knee will go into valgus, and you'll see a non-traumatic, often grade 2 straight instability of the medial collateral ligament. And it's just been overstretched and overstretched and overstretched. On the other side, your leg is trying to lengthen, mostly by muscular action. So basically it stretches the leg out, and which is fine unless things can't work properly. So here, neurophysiological effects are often present where the muscle is weak, and so it's prone to degeneration. So degenerative tears, tendinoses, or the joint can't basically lengthen there, so other joints have to lengthen more and they break down. So overcompensation is pathological, compensation is normal. Now, neurophysiological influence is reflex inhibition. It's the only one that occurs within the unit. The chances are it's not actually an etiology. It's not helping much, but it's not an etiology. It's probably caused by that joint that's in trouble. But that's the only one that can, because segmental facilitation actually spans multiple units. It spans the whole quadrant, essentially, certainly S1, S2 does. They'll span the entire quadrant over that segmental distribution. So you can't consider this as an intra-unit effect. Now, so neurological is the same thing, but for it to be an effect within the unit, it has to be a peripheral nerve or a terminal neuropathy, or either causing axoplasmic flow loss alone, or electrical conduction loss with axoplasmic flow loss. So these would be within the unit. And these can be single or multiple crush syndromes, but the distal crush must be within the unit that's causing the problem. Okay, so let's have to look at some examples within each unit. Mechanical, straightforward force on bone. The joint can't move, so it can't take its place in compensating for another dysfunction, or it directly stresses out a joint nearby. So examples of this would be the hip joint destabilizing the SI joint and or L5S1. Now this is made a lot worse if the hip joint that is stressing out L5S1 when the SI joint is sublux interflexion and it can't take its place in compensating for the hip joint loss of mobility. So now the lumbosacral junction takes much more stress than it would do if the SI joint was contributing, and so it breaks down faster. Or if you like, the ankle destabilizing the midfoot because it's sublux interplantar flexion, can't dorsiflex, so you start to over dorsiflex the next joint is capable of doing that. Now there's enough movement loss in the ankle to possibly do this all by itself, same as there was in the previous example. But now if you add on to that an inverted calcaneus, where the calcaneus can't evert to help flatten out the foot, then the force on the mid-tarsal joints is that much worse, and so it breaks down faster. What hasn't been mentioned here is that you also need an external force here. It's not just the joint not doing this. If I have a hip joint that can't extend, I spend all of my life pretty much working at a desk, going for slow walks, not doing anything athletic, not fast walking, not running, then that extension hypomobility of the hip is not going to make itself felt. So you also need the force that's going to provide the impetus to get this thing breaking down. Neurophysiological reflex inhibition, because this is an intra-unit problem, it's the only one we can talk about. So if I've got a flexion subluxation of the SIJ and it's causing weakness of the lower multifidus, which it can do as the muscle does run over it. If a hip extension hypomobility is present and it starts to stress out L5S1, this is going to be amplified if that multifidus is unable to provide dynamic control to the L5S1 segment, and it will break down faster. It's not to say that even if the multifidus is doing its job, it's going to be able to withstand those forces, but it should make it hold on a little bit longer than it would do normally. Neurologically, it's going to be the same as neurophysiologically because of the weakness it's causing, and again, you lose dynamic control. So they're the effects, examples of the effects within each unit. Okay, we're going to have a quick introduction to long leg, short leg, regional lower quadrant effects. We're not going to spend a lot of time on this, this will come later. What I want to get is the simpler stuff away, the principles of this, and then we can worry about the more complex issues. But as an introduction, first of all, a long leg is not a leg that's longer than the short leg. It is, but it's not a relative term. This is an absolute term. The leg is longer than it should be. On the other side, the leg is shorter than it should be. You can measure this by watching them walk. If you have an uncompensated or overcompensated long leg, then you'll see the patient come up and down it. So there'll be a vertical limp. They'll go up and over it and down. It's like vaulting over this, because the long leg, if you think about this, where in that stance phase, everything is close to its close packed position. The ankle is dorsiflexed, the knee is extended, the hip is extended, or moving into extension, the foot is pronated. So everything's moving towards its close packed position, and there is no give to it. This is the definition of close pack, is that this is about as stable as a joint can get. So this becomes a rigid thing. So if it's longer than it should be, you vault over it. On the other side, things are away from their close pack position, and there's give. So a long leg, you'll see them bolt over. A short leg, shorter than it should be now, you'll see them basically sort of collapse to that side. So you'll see a lateral limp with a short leg and a vertical limp with a long leg. I think the long leg is more consequential because there's probably more impact, because there's less movement available in these close packed joints. There is more consequences to joints that can't get in that position. So long leg, short leg. We'll have a short discussion about causes, and then we'll leave that alone for the rest of this module. All right, so let's look at the effects between units. First, mechanical. These are generally direct forces, mostly affecting the knee. If you think about this, you've got body weight going down, ground reaction forces coming up, and the knee is stuck in the middle of all this. Now, when you're standing on your leg, your knee is pretty much locked into extension. So it doesn't have a lot of places to go to accommodate for these forces if something else is in trouble. So all it can do is hyperextend, abduct or adduct, all of which are not normal movements and will break the joint down quite quickly. So you'll often see problems around the knee that are either symptomatic or not, but are indicative of intra-unit problems. The lower thoracic spine from about T7 through L1, L1 is included in this because it's the same anatomical configuration as the rest of the thorax. You have basically these joints have to be able to accommodate forces coming up through the limb, and if they're jammed over and they can't move in the appropriate direction to accommodate those upgoing forces, then the joints below them will have to do more to actually compensate so they can break down because of it. If we have a problem in the upper lower thorax, say 7-8, and that can't accommodate, then you're likely to see problems coming in the lower thoracic as it were. So T11, 12 is not an unusual area to start seeing these problems occur. Neurophysiological considerations, segmental facilitation is a big one here, obviously, and it can cause weakness anywhere within that quadrant, providing the nerve root supplies that far down. But certainly S1, S2, even L5 will span the whole quadrant. These are the ones that tend to be in trouble. Neurologically, pretty much anything. Single crush, multi-crush, radiculopathies, axoplasmic flow problems are all going to lead to weakness in the muscle and their inability to control joints or to lengthen the limb, for example, without breaking down and becoming degenerate. So these are the effects between the lunars. So what we're going to look at next is long leg and short leg, but we're not going to spend a lot of time on this. This is a bit too advanced for where we are at the moment, so we'll look at a very easy introduction to it, and we'll get into it more later on, a lot more later on. Okay, let's look at regional effects now. In its essence, this is about long leg versus short leg. Now, let's get this out of the way first. A long leg isn't relatively longer than a short leg. It is, but that's not where we're going with this. A long leg, in our terminology for this, is a leg that is longer than it should be. A short leg is a leg that's shorter than it should be. And obviously you can have structurally long, structurally short legs, but we're not talking about that. Now we're talking about things that have changed it quite rapidly from a long leg to a short leg, or a short leg to a long leg, or a short leg to an equal sized leg, and so on. But these are reversible changes that we're really interested in here. So if we look at the causes of these, the major causes are at the hip, that when it can't fully extend will produce a long leg. At the ankle, with basically a dorsiflexion hypomobility, which means you're basically walking on your toes a bit, so the leg is long, and less commonly is an extension subluxation of the SI joint, a primary subluxation now, not a compensatory subluxation. So these are the major causes of a long leg. Contributors to a long leg are stuff that make the leg longer, but really don't have the ability to produce a massively lengthened leg. So these do not allow the leg to shorten, basically. So these are contributory etiologies that stop the compensation at those joints that are immobile or hypomobile, and make the joints that are mobile be excessively mobile and break down. These include flexion subluxation of the SI joint, dorsal subluxations of the fore and midfoot, inversion subluxation of the calcaneus, flexion subluxation of the L5 S1 facet, and transverse subluxations of L5 S1, where the side flexion that goes with the transverse subluxation doesn't allow it to basically extend on the ipsilateral side. So all of these things stop compensations from occurring, because the normal compensation for a long leg is what you can see when you twist your body on your feet. So if you stand and twist to the left, say, what you'll see, let's twist to the right. If I twist to the right, what you'll see is the right foot will invert, and that's in order to keep the foot on the ground. The knee can't do much. The knee is straight when you're standing, and any movement away from that straight will shorten it, but there's no real force going through it, and you want to lengthen it anyway. So its lengthened position is when it's extended, not hyperextended, but extended. And if you feel the innominate on that side, on the right side where you're twisting, you'll feel it rotate backwards to extend the hip and lengthen the leg. The spine on that side will go convex, so the joints are flexing and again lengthening that whole quadrant. On the other side, if I'm twisting to the right now, you'll see, twisting to the left, you'll see the foot flatten on the left side. The knee will valgus a little bit and hyperextend. The innominate will rotate anteriorly, and the spine will become concave on that side, extending those joints and shortening that leg. So if I'm twisting the right, the right leg needs to lengthen. If you stand on a trampoline and do this, you'll see that right leg go down, but the trampoline isn't there, so you have to shorten the leg so it scrunches. On the other side, the foot has to lengthen to stay in touch with the ground, and that's what the normal compensations are. If they can't do that on the long side, things will break down, usually mechanically break down. On the other side, where the lengthening is being caused by muscle activity, and if these muscles can't tolerate this, you'll see degenerative tears, tendinoses, and sometimes the joints will be forced into positions where it doesn't want to go. So if everything's working fine, and we all have inequalities in the legs, leg length inequalities, then there's no limp, there's no dysfunction, everything's working fine, everything's working within their safety limits. So they're compensating, but they're compensating well within their safety limits. If a joint or joints cannot take part in that compensation, then things start to break down, and that's what you see. This was a very short introduction to etiology searches. It's a fairly complicated procedure, and it's interesting. This is, for me anyway, the most interesting part of manual therapy. Making the diagnosis is generally very simple. Doing the technique is very simple. All of this takes time to learn, but it's all very simple and straightforward, and there's not an awful lot of brain work involved in most of this. This stuff, though, can be very interesting. What is also interesting is that the likelihood is that you will never find the ultimate cause of what all this is about. Um, for example, let's say we're dealing with an extension hypomobility of the hip. All right, so a patient comes in, they're complaining of L5S1. No, let's say they're complaining of medial knee pain. All right, you examine the knee. There's no trauma. You examine the knee, and you've got a straight instability of the MCL. There's laxity there. It's tender and it's painful when you stress it. Fine. Now, what could be causing that? Well, the first thing that sort of goes through my mind is a long leg could cause this, because if you've got a long leg and you've got something that's not playing nicely, then the knee tends to abduct and extend to shorten the leg. It has to, because other joints are not doing its role. So now you've got two jobs. One is to try and find the source of the long leg, and the other one is to try and find out why the whole leg, the whole quadrant, isn't compensating for it and therefore not stressing the knee. They're your two jobs. So let's say that you find that you have a hip extension hypomobility. Okay, there's your probable cause. Okay, this is a major cause of a long leg, and away you go. But something else is contributing to this by not doing what it's supposed to do, and you find, say, an ankle that is subluxed into plantar flexion. Now, neither the hip nor the ankle are painful, but the pain's in the knee. So you go, okay, well, we'll manipulate the hip, we'll manipulate the ankle, and away we go. Fine, you take the stress off the knee, and everything's better. Your next question to yourself should be, okay, that's fairly straightforward. Why did the hip become hypomobile? Why was the ankle subluxed? Okay, the ankle, there may have been an old injury, so they've had an inverted injury and that's done it. But why did the hip go? Well, the hip is a primary centre of osteoarthrosis. It's the most replaced joint in the body. It seems to break down for no good reason at all, but there's always a good reason for it. Why not the other one? So this may be a retroversion, increased Q angle of the neck of the femur, anteversion there. You really don't know, and you probably never know. So often you never know what's causing it. Now let's say you treat both the ankle and the knee, and the pain comes back, and you find those two have gone. So the question is, why didn't it stay good? It may be that the patient didn't comply with the rehab, or it may be that there's an axoplasmic flow problem, and there's no nutrients, or not enough nutrients going to the medial ligament, and this is now your next avenue of attack. Where could this flow problem be? You check the muscle strength, you find it, and you try to find out where this block is. So this gets really interesting, but it also gets quite frustrating. But without this, I think that manual therapy can be truly, truly boring. Once you master the diagnosis, once you master the techniques, it becomes routine and you're ready to move on. Whereas the etiology is always changing. There's always something there that doesn't quite work, and it can be mentally exhausting as well. So this is what I find interesting. This is what it keeps me getting up in the morning, more so than treating patients with diagnosed treatment and getting on with my life. Okay, I hope you enjoyed this and it got somewhere with you. See you later.